Thank you for tuning into this session on atrial fibrillation. I'm your main speaker for today. My name is Dr. Mohammed, and I am a doctor in accident and emergency and general practice. So I've got one leg in both fields and have been invited kindly by Medicine's Academy to give a short presentation on atrial fibrillation. Atrial fibrillation is a disease that we commonly encounter whether we're in primary care or secondary care. But I guess I'll start with a secondary care example that I faced myself actually, which kind of tells us or informed me definitely of the importance of managing it, picking it up and managing it effectively early on so that we can avoid any complications. I once had a 81-year-old, very lovely Italian lady who came in accident emergency complaining of maybe about 4 or 5 months of feeling quite weak, lightheadedness, some intermittent palpitations. And her daughter decided to bring her in. Sorry, it was her daughter-in-law that decided to bring her in just because she felt she only really mentioned it the last time they met, which was a few days ago. And the daughter-in-law became a bit concerned and brought her into A&E. I had a chat with her, nothing really specific in her history other than just very, what we would say, vague symptoms. Feeling a bit lightheaded, a bit tired, some palpitations. Decided to do some blood tests to see what was wrong and kind of treated it as initially tired all the time kind of thing. Also did an ECG as part of the workup and realized that she was in AF. She wasn't necessarily in fast AF. She wasn't necessarily in slow AF. She was just in atrial fibrillation. She was just in kind of slow atrial fibrillation, ventricular rate of about 80 something beats per minute. And all of her blood tests actually turned out to be completely normal, and it was concluded that she's probably had atrial fibrillation for many, many months. I spoke to the medical registrar, explained to him the situation. He came down and he had a good chat with the patient, as well as myself explaining what atrial fibrillation was, what it means for you, and most specifically the need to be on anticoagulants to avoid any problems. Now, her main issue was that why is this something that I've only picked up now? I've been to my GP on multiple occasions, complained of these palpitations, etc. And my GP and my practice nurse, and no one's actually bothered doing an ECG, just putting it down to just general fatigue and just, getting old. Naturally, I wasn't in a position to justify the actions of any other clinician. I just said, look, this is something that can happen. It's something that presents incredibly vaguely. The main thing is that we've managed to pick it up. We decided to anticoagulate this lady based on some scoring that we did, which put her at a bit of a risk to having a stroke. We decided to put her on some rivaroxaban. The issue with this was that in A&E it was out of hours, so we don't actually stock much rivaroxaban. We do, but we ran out of stock dealing with someone else. The medical registrar decided to print out a prescription of rivaroxaban for the patient to go home, and the patient can then come back and then basically tomorrow morning to the pharmacy and pick up some rivaroxaban, and the GP can follow up. So all of that was set. What happened afterwards was that went home, got home, my wife made me a really nice curry. I was relaxed, had some dessert after that, did a bit of movie watching, and then basically just went to bed and went into work the next day, only to see her name on the screen, on the patient screen. And I thought, hey, I'm sure we discharged this lady yesterday. Why is she back? What's happening? And the medical registrar, who was also on with me, who I was in regular correspondence with, was also there first thing in the morning the next day. We discharged the patient. She went home. I'm sure she went home and had some food, relaxed. Her daughter-in-law said that she'll stay with her the night. But what happened was that her daughter-in-law woke up in the middle of the night to check up on her and realized she had a left-sided weakness, facial droop, a kind of speech disturbances and other things. In other words, she's basically had a stroke, and she's come in and she's had a stroke. She had been thrombolized, but unfortunately the thrombolysis made no difference to her. And kind of we were told about it. There was nothing that we could have done differently. Maybe in retrospect giving her some tinzaparin anticoagulant in the meantime, which may have perhaps solved the issue. Fortunately, we weren't able to do anything differently. But the actual incident highlights the real importance of treating atrial fibrillation, to contextualize this discussion, hopefully, some of the severe complications that it can potentially cause. Atrial fibrillation is classed as a supraventricular tachycardia, so the actual rhythm abnormality is generated superior to the ventricles, and it is postulated to be generated in the atria in particular, more specifically in the left atrium. AF results from irregular, disorganized electrical activity and ineffective contraction of the atria. It's most commonly found in the elderly. It results in a 10 to 20% reduction in cardiac output. In terms of its prevalence, atrial fibrillation is postulated to have a prevalence of about 1% at the maximum, with an incidence of 0.54 cases per 1,000 persons per year. It's relatively quite prevalent. We'll see it a lot in our practice. Men are affected more than women, and definitely it's more prevalent in people who are of an older age demographic. It's likely that about 1.25 million people are likely to be affected in Britain, but these are 1.25 million who have not actually been diagnosed with AF. So there is a large population of patients who are yet to be diagnosed, and it's estimated to cause about 100,000 strokes, or 100,000 strokes in the UK alone are caused by AF as a single causative factor. In terms of its pathophysiology, and I think it's important to go into this slightly. I mean, the first caveat is that not much is known at all about AF, to be honest. It's one of those silently producing things that is actually just kind of controlled in terms of the approach is more symptom control than it is kind of actual solving the problem. AF, like I mentioned before, is largely to be postulated to start from abnormal atria, in particular the left atrium. So it's said to be due to dilatation and fibrosis of the atria, which is either due to long-term ischemia or is due to valve abnormalities, which causes basically a difference in cardiac refractory periods, which makes sense slightly. So, for instance, if your cardiac myocytes are dead, they are going to be less likely, or less able rather, to conduct cardiac transmission in a more in an efficient way, subsequently delaying things like refraction, delaying things like transmission, and naturally the heart subsequently loses the uniformity of this transmission of the transmission of this contraction and electrical impulses, subsequently creating rhythm abnormalities. Certain risk factors that are really, really important, especially for us to keep in mind. And when it comes to acute AF, please, guys, remember, infection is the main cause. Infection is the main cause. In the elderly, it is dehydration. It's usually secondary to an infection. So if it's acute AF, always think, is there an underlying infection going on? If it is not, then we need to start to look for those things that may have caused dilatation or fibrosis. So it might be ischemic heart disease, it could be hypertension, it could be an underlying valve disorder. All of these things will negatively affect cardiac myocyte contraction and cardiac myocyte impulse generation and transmission. There are certain lifestyle things that living in a workaholic society that we need to really look out for. So in particular, caffeine. You'll find that lots of people have lots of caffeine. Lots of us are included in that category. Lots of cups of tea, but more specifically, lots of cup of coffee, lots and lots of coffee actually. And alcohol is another one. So alcohol is a very well-known precipitant of atrial fibrillation. I'll start off with the bottom of this slide. Atrial fibrillation is often asymptomatic. It's quite conspicuous in the way it presents. Not to make this a crime drama or Sherlock Holmes, but it is quite conspicuous in the way it presents. It can present with dizziness, fatigue, very general. It very rarely actually presents with palpitations and shortness of breath when it's particularly fast. But the most specific sign actually that we can elicit that will tell us, and that we all need to be really good at actually, is an irregular pulse. We need to be feeling the pulses of all patients that we see, and that's just a general rule within primary care and secondary care. An irregular pulse, and getting good at feeling the pulse, so that is feeling both hands, both sides, and subsequently counting and trying to work out whether it's in rhythm or whether it's not in rhythm, is probably the most important skill that we need to develop in the context of cardiovascular disease. Yep, feel your pulses, guys. Atrial fibrillation is categorized in various different forms. So I start off with a term that we'll probably be coming across quite often, which is paroxysmal. Paroxysmal AF is AF that comes on and then goes off. It's usually realized as a result of patients complaining of short but sustained period of palpitations and symptoms, which subsequently just settle themselves. So all of these symptoms, but a short period of time, and then they completely settle and they're completely back to normal. These patients may find that these symptoms are specifically surface at particular times of day. So that could be the morning, that could be the afternoon, that could be the evening. So it's important to take quite a thorough history in this respect. More common types of AF include persistent atrial fibrillation. The rest of the categories are kind of what constitute, sustained AF or atrial fibrillation without any caveats, as what we know it. So this could be persistent. So this could last for 7 days or less, kind of when treated, and it lasts for a good amount of days. It's treated, it solves, but then it comes back again and it needs to be treated again. It could be long-standing or persistent, so it's continuous atrial fibrillation that's resistant to treatment over a year or longer, whilst permanent AF, which is what we are most accustomed to, which is present all the time, which normal rhythm cannot be restored without treatment, basically. And this is the type of AF. And to be honest, our webinar and our discussion concerns all types of AF, because even with paroxysmal, within that period that they do have sustained symptoms, or sustained AF to be more precise, their body could develop a clot as a result of atrial fibrillation. So that brings us to another part of the discussion, really. Why do clots form in atrial fibrillation? And it's quite simple, to be honest. If you imagine your heart fibrillating, small contractions happening lots and lots of times over a short period of time in random parts of the heart, that's basically what AF is describing. In this instance, you essentially have insufficient or inefficient cardiac filling, inefficient cardiac emptying, inefficient cardiac contraction, so blood basically remains static in a lot of times within the heart. And what I mean by that is that this blood isn't moving anywhere, right? Because the heart isn't actually contracting to its fullest potential. This blood remains in the ventricles or remains in the atria and just gathers and just gathers and just gathers. Now, the result of this gathering process, unfortunately, is that when blood stays static or isn't moving, it tends to clot. And subsequently, in the context of AF, this blood can clot. It may shoot out of the heart via the aorta and subsequently go anywhere. So it might go up via the carotid arteries into the brain. It might go down the coronary arteries at the root of the aorta and cause a clot or a heart attack, basically. It might go further down into the abdominal aorta and may even clot the renal arteries, or may even clot the mesenteric arteries, causing small bowel ischemia or causing a renal infarction or something like that. All of these various different things can result as a result of AF. So it's important to treat it. So how do we diagnose atrial fibrillation? The most important thing is taking a pulse. Take your pulse, you'll realize that they've got an irregular pulse. There you have it, guys. That's your diagnosis. At that moment in time, we're not really concerned about whether they've got paroxysmal AF or whether they've got long-term AF or whether they've got permanent AF or long-standing AF. We know at that moment of time, when they're in your clinic room, they have atrial fibrillation. But where to go next? The initial investigation that we can do in-house is a 12-lead ECG. And that 12-lead ECG will display an ECG like that which is on the slide. An irregular pulse as well as a lack of P waves. And P waves correspond to atrial contraction. So a lack of P waves means that the atria are not actually contracting properly or not contracting at all, which is in keeping with the fact that there is a rhythm disturbance coming from the atria. But what's the problem with doing an ECG? And the problem is really simple. Doing an ECG only gives us a snapshot image of what's happening. We might find that the minute they leave your consulting room or the ECG room, their AF settles. So they might actually have paroxysmal AF. Who knows? They may not have AF when they come and see you. You may suspect it. You may do an ECG, and their ECG might be in normal sinus rhythm. But the minute they go home, they go back into atrial fibrillation. So in this instance, And what I'm describing here is a paroxysmal picture. We need to perhaps arrange some longer monitoring. That could be a 24-hour or 72-hour tape that allows us to look at the rhythm and look at periods of atrial fibrillation over a longer period of time. I guess it's time to talk about the prognosis of patients with atrial fibrillation. So we've spoken about stroke and thromboembolism. About 20% of these patients, of patients with strokes, actually have a background of atrial fibrillation. So not treating atrial fibrillation is probably one of the causes for a stroke to happen, and it's probably one of the worst feelings that you can have as a clinician, where you know that you could have perhaps done a bit more to prevent something from happening, as illustrated by the story that I gave at the beginning of myself and the medical registrar. Heart failure is another complication, guys. Heart failure, as I've mentioned, can result from atrial fibrillation. And when patients with atrial fibrillation develop a bit of shortness of breath, this could be a sign of early heart failure happening. The reason being is because in the context of AF, the heart isn't pumping very well. The atria are fibrillating, the heart itself is fibrillating. So subsequently, the amount of blood that's actually being pumped by the heart is less than what it normally should be. And subsequently, because heart failure is defined as cardiac output not meeting the needs of the body, cardiac output is reduced, and subsequently the patient goes into heart failure and develops some of these symptoms. Ischemic heart disease is something we've already discussed, and that is as a result of a clot firing off from the atria, going up the aorta, and then subsequently going down the coronary arteries and blocking circulation of blood to the heart and causing a myocardial infarction. Finally, AF does produce a 46% increase in all-cause mortality. So it's really important that we get on top of treating it. Some more stats that we've kind of found and we've researched. So AF-related strokes have a 30-day mortality rate of 33% versus 16% for non-AF-related strokes. AF is indeed a contributing factor in up to 1 in 5 strokes in the UK. So it's really important for us to deal with it. So how do we ensure that we're spotting some of these cases? Because like I've mentioned, there are lots of cases of undiagnosed AF. How do we practically screen these patients as they come into our clinics? So NICE have got some excellent guidance when it comes to screening patients for AF, and a lot of it is what I've mentioned before. Check their pulse. That's indeed the best practice. The preferred method of screening, especially in patients in over 65 years, is an opportunistic pulse with a follow-up ECG if you're in doubt. And NICE actually recommends that an ECG has to be performed in all patients with suspected AF, i.e. if they have an irregular pulse. So once we've perhaps got a patient who has got atrial fibrillation, so we've diagnosed them with a pulse and we've done an ECG that confirms it, whether that be an in-house kind of snapshot ECG or even 24-hour ECG, we need to now decide whether it's worth treating them or not. And I say that quite carefully, because sometimes we will find that in certain demographics of patients, it may not necessarily be in their interest for us to treat them using some anticoagulation therapy, such as, for instance, the elderly. Elderly patients, of those who may have very poor mobility, will be very susceptible to falling down, will be very susceptible to sustaining other injuries that may result in internal bleeding, such as head injuries. So we need to decide whether it's actually in their interest of being on anticoagulant therapy in light of their mobility and their general frailty. What we have with us is 2 useful tools. I'm not sure why, but the title of this slide isn't projecting, but the title of the slide is CHA2DS2-VASc versus HAS-BLED. A CHA2DS2-VASc score is a scoring tool that we have as clinicians that helps us decide whether a patient needs to be anticoagulated or not. So if we've got a patient who has got atrial fibrillation or we suspect to be at risk of having a stroke, we conduct a CHA2DS2-VASc score. And within this are certain cardiovascular and prognostic parameters that we consider. Do they have hypertension? Do they have diabetes? Do they have congestive heart failure? Have they had a stroke in the past, as an example? Are they male or are they female? A score of more than 2, or well, a score of 1 tells us that we should perhaps consider anticoagulation therapy. whilst a score of more than 2 tells us that we should definitely start them on some anticoagulant therapy. We balance that using a Hasbled score, and it's incredibly important that we do this, because a Hasbled score tells us or informs us of a patient's bleeding risk if they were to be started on an anticoagulation therapy for atrial fibrillation. For instance, do they have labile INRs? Is their INR not very consistent, as an example? But more specifically, do they have abnormal renal function? Do they have abnormal liver function? Do they have hypertension? Because someone who has got hypertension is more likely to bleed out. Are they taking alcohol? Because alcohol really kind of deters someone's clotting function and ability to coagulate. So these are very important considerations that we have to take when we're weighing up a decision about whether we want to anticoagulate them. But if you notice, guys, from this Hasbled score, we don't have any scoring for mobility. We don't have any scoring for frailty. We don't have any scoring for elderly patients. We don't have any scoring for a lot of these lifestyle issues that we can often take for granted. And it's important in these moments to take comprehensive social history and also seek advice where we can, whether that be via a clinician at your practice or another clinician at your hospital. So it's important to be quite comprehensive in this regard. So managing AF is the next puzzle, and it is a puzzle because there isn't really any right answer and there isn't really any wrong answers, but there are some guiding principles that we do have that make sense in terms of physiology and pathophysiology. Now, if they have developed AF quite suddenly within the last 48 hours, we need to think about why they've done this. So like I've said, AF acutely is almost always due to infection. So we treat the infection and we assume that the AF will self-resolve if they have an infection. But in primary care, we can't necessarily take this chance, really. If there's someone who's older, likely to have had AF for a long time, that's fine. We can deal with that. But if they're young, fit, and they've just developed AF and they're symptomatic with it, then we need to be thinking about, oh no, have they got an infection or do they have an underlying rhythm abnormality? So we treat the infection. But let's say in secondary care as an example, and let's say the infection has been treated, but they're still in AF. If the time of onset is less than 48 hours, whether in primary care or secondary care, they may need cardioversion. They may need a shock. And this shock at this specific time has been found to be very effective in dealing with someone's AF. Other lifestyle factors are important to consider, for instance, so weight loss and dietary changes, sleep hygiene, and managing other conditions as hypertension. But these three are only in the context of longer-term atrial fibrillation. If patients have had it for more than 48 hours and they are subsequently at risk of having a stroke, or they're symptomatic with their symptoms, we need to make a decision. Can we anticoagulate them? We do a CHA2DS2-VASc score immediately, and we do a Hasbled score. And for us in primary care, we have some very useful tools that automatically calculate this. But you can always go to other places like WebMD, for instance, who provide us with some very useful tools that we can use at our fingertips. Some of these patients will need to be admitted. So for instance, if patients have developed AF after they have got heart failure, as an example, then these patients need to be admitted. If patients, for example, have a valvular heart disease, which has preceded their AF, so they've got AF secondary to a known valvular heart disease, then these patients need to be admitted to the local acute medical unit. If there is suspicion of another underlying rhythm that may be masked from the AF, this is a bit tricky, and this will be pointed out via the ECG report that will be given by the cardiologist or the special interest clinician who's looking at the ECG. If he or she sees any suspicion or any sign of an underlying excitation syndrome, for instance, then they will tell you, and these patients will require urgent referral. But in the normal circumstance, after deciding whether we want to anticoagulate these patients, we need to make a decision. Are we going to rate control them, or are we going to rhythm control them? Rhythm controlling doesn't happen in primary care. It happens in secondary care. You'll need to refer these patients for that. But you would only rhythm control, and the easiest way to think about this is in someone who is young and healthy. And the reason why is that their hearts are still developing, their hearts are still young, their hearts are still moldable, their hearts haven't got any other structural abnormalities. So subsequently, the heart can still remold. the atria can still remold, that fibrosis can still come out or kind of solve itself. Those valve problems can still be operated on, or those valve problems can still be mitigated. So we start these patients on rhythm controlling agents such as amiodarone, flecainide, sotelo, for instance. But in the majority of patients that we will encounter who will be elderly, who will be anticoagulated, a rate control treatment is sufficient because they're past that age. That cardiac remodeling age is long gone for them. So we can just aim to slow down their heart and control the rate at which their heart is beating to maximize cardiac output, to maximize contractility, to keep that blood in their body moving at a good rate. So we start them on bisoprolol, or if they're asthmatic, then we need to change them and start them on perhaps some digoxin. But a lot of this will be determined by local guidance. Finally, how do we monitor these patients? We monitor these patients quite simply in accordance to whatever anticoagulant they're on. So many of our patients, especially those with renal abnormalities, will be on warfarin. We need to do serial INR checks. So that would start off as kind of regular, and then subsequently, depending on the patient's INR, how labile the INR is, we can start to reduce the frequency at which we test these patients' INR. But an annual review of these patients is always recommended because atrial fibrillation can produce lots of cardiovascular complications, long-term complications, and they need to be tended to. So for instance, we measure their heart rate, we measure their blood pressure parameters to have a snapshot view of how their cardiovascular health is doing. Medication, we check their INR trend and their compliance, and we always try to make the attempt to change them if they are on warfarin to something less to something like rivaroxaban or apixaban, something that will be less of a burden to them, and a drug which we know is less susceptible to being mobile in its labile rather in its anticoagulant effect. And annually we are to check the CHA2DS2-VASc score and Has-Bled score because these things are static. Within a year, patients can develop lots of comorbidities, so it's important to always evaluate the decision as to whether it's still wise to anticoagulate them, or whether now things have changed, and whereas previously we couldn't anticoagulate them, perhaps now it's suitable for us to anticoagulate them. That's atrial fibrillation, guys. Hopefully that's been an educational experience for you all and has provided some sort of comprehensive framework by which we can deal with atrial fibrillation. But yes, hopefully it was of some benefit. Thank you very much.